Local productions seen on Delta College Public Media are made possible with support from viewers like you. Thank you.
Hello, everyone. Welcome to Junia Doan's The Spark. I'm Junia Doan, and this is a very special day because it's the very first Zoom interview I'm doing. And the reason I'm doing this is we have been self-sheltering for just under 6 weeks if you follow Michigan governor's self-sheltering rules, or just over 6 weeks if you're looking at the New York governor's regulations. In any case, self-sheltering means you basically stay home and you avoid people. Many of us have masks, we're taught to disinfect, we wear gloves, to touch things. We're concerned about virus spreading because this Wuhan virus, COVID-19, is very serious. They don't seem to know much about it and even how to treat it. Some approaches work better on some and not so good. It's a terrible death. Because your lungs fill up and you basically are suffocating or drowning. In any case, I thought it'd be interesting to do a series of interviews with some of those people who are professionally in a position to respond to this challenge successfully so that our lives will be easier and more manageable, limited as it is right now. So please join me. In welcoming Tom Wood. He is a director of trauma and virtual care at MidMichigan Health, right here in Midland, Michigan. Tom, we're so happy to have you here, and thank you for taking time out of your most busy schedule at this time, and really every time. So tell me about your job. What was it before the virus hit?
Yeah. So my job's the same. It just got a lot busier. I am the director of trauma and virtual care for MidMichigan Health. So trauma is, it's kind of a dual job. So trauma is a lot like what you think. It's the acute injury side of things. So if you were in a car accident or fell or anything like that, my team is the team of surgeons, a team of nurses that help take care of the patient for those acute injuries. And really our goal is to get you back to what you were before you had the injury. The other half of my job is what's really gotten crazy, and that's virtual care. Virtual care is kind of an all-encompassing term. You hear it called telemedicine, telehealth, virtual health, e-health. It really all means the same thing. And for not getting technical with it, I would say it's really just when we use technology to provide healthcare remotely. In this setting, after COVID-19, it's really how do we get to people where they are, which is for most people in their home, and still provide their healthcare needs for them. And we've been doing that for a long time here. We do it in kind of 3 flavors. We do a lot of stuff in the hospital. So we have a lot of rural hospitals at MidMichigan Health. If you think of our Alpena hospital, 3 hours north of here, beautiful location, but very isolated, hard to get to, and not a lot of specialty doctors there. So we've always had a problem of if somebody's having a stroke up there, there's not a neurologist that can come in and see them in the emergency department. And what do? And years ago, we partnered with University of Michigan and put our telehealth equipment up there. And now the neurologist and stroke team from the University of Michigan sees the people in the ER up there as if they were walking into the hospital in Ann Arbor. So they're getting state-of-the-art stroke care. So that's the type of stuff we've been doing for a very long time. And that's just a small example. MidMichigan, before COVID, we were very fortunate. We invested heavily in our virtual care. We've spent a lot of years, frankly, doing pilots that failed and learning lessons from it and figuring out how to do it best. So we were very adaptable when this came along. Before this, we were somewhere around the 2nd largest telehealth network in the state of We didn't do a lot of in-home stuff. we didn't have a lot of huge demand for it at the time. And that certainly is what changed with all this. We went from doing 100 to 200 in-home visits a year to about 15,000 since mid-March.
Boy, what a curve up.
Yeah.
So tell me, how does that work? Say you're a patient of a doctor who knows you and you think you have an earache or
Yep.
you have some kind of virus or some kind of bacteria, and you call up the office. What happens next in a telemedicine sense?
Yeah, so we try really hard to make the experience as much like as if you went to the office as possible. I mean, you and I are apart right now. We know this isn't the same as an in-studio interview, but it's very, very close. And we try to do that exact same thing. So you would call your office and they'd talk to you. You'd talk to the nurse or the receptionist, the same as always. Give hey, I woke up with an earache. Maybe I have a sinus infection. Or it could just be, I'm running low on my medication that I've been seeing you for 20 years for, and I need to see my doctor. And at this point, they work with you to make sure, do you have a smartphone? Do you have a tablet? Do you have a laptop? Do you have a family member that can support you? Do you have a caregiver that can do that sort of thing? And if so, all I need at that point is your contact information. One of the things we did is we partnered with a vendor that does not require the user to download an app. They don't have to be tech savvy. They don't have to create an account. They have to be able to click a link. So I can email you the link, or a lot of them, they just ask us to text it right to their phone. You'd have your appointment time like normal. When it came time for you to see the doctor, they'd text you that link. You click it. It asks you, what's your name? Type your name in real quick. It puts you into a waiting room, no different than the waiting room you would have at the doctor. And when the doctor's ready, they click a little button that says stop call, and they pop right on your screen and begin the talk. No apps to download, no login. It's great.
But let's say you had an ear infection. Are you taking your camera and going, here's my throat, here's my ear? What?
Yeah, so first off, there are products that do that. We don't do that right now. There's a lot of stuff we see routinely that's kind of on the future. Some of the stuff we're seeing today are stuff that vendors were trying to sell me at conferences 3 years ago, and they were startup companies. And now they're multi-million-dollar companies. I mean, that's the nature of telehealth right now, is we are still very much in the infancy and very much on the way up. So there are limitations to the exam. Virtual care will never replace an in-person exam. Never replace. It will supplement. There are visits it can replace, but in terms of going to your doctor's office, I have no vision in ever saying, we don't do that anymore. You see them all over video. We don't want to lose that human touch. And there are exams that can't be done. With earaches, I'm an ER nurse by background. I used to work pediatric ER. And so, I worked adult and pediatrics, but I got trained in how to take care of kids, and there's just not a lot of people that are comfortable with taking care of kids. And so I went to a hospital that had a separated pediatric ER. I got put in there a lot. I'd be working the triage area. A 4-year-old would come in. They'd have a beet red ear from ripping on it. And mom's like, they're ripping on it. They're drooling. They've got a fever. They're not listening as well. It's an ear infection. We know it's an ear infection. Sure, a doctor's going to put a scope in and look at it, but we know that from symptoms. And so there's our doctors are very, very smart. They go through a lot of schooling, and they are blessed with lots of technologies, x-rays, CAT scans, MRIs, but doctors know how to clinically diagnose many, many, many conditions. And it's no different than for decades, many people have been able to call their doctor and say, it's the same as last time. I have another urinary tract infection. I have another sinus infection. I'm at work. Do I really need to come in? And we know for years doctors have been able to make those diagnoses over the phone. This gives the added extra layer. There are things they can see. There's a lot of times they say, my throat's sore. Say, shine a light, look right in.
So you're saying in this particular case right now, the hospital can't treat, or the doctor can't treat. Here's my ear, here's my throat with a smartphone. Did I understand you or not?
Oh, so what they do is
you can, so they can say you need an
judgment.
antibiotic, you don't need an antibiotic, you need to wash out your ear, and
Yes.
they can arrange all that?
Correct.
Oh, that's fantastic.
Yeah, so they do their clinical judgment. And the key with clinical judgment is it's not, the doctor doesn't sit there and say, I can do everything for everyone. My ear is different than your ear, it's different than my wife's, it's different than my children's. And our doctors know they're using their best clinical judgment with the information that's presented for them. Our urgent cares and emergency departments are still open. Our doctor's offices are still capable. They have to go through a lot of extra steps to maintain social distancing and make sure we're not mixing people together. But in the end, if you need physical care in person, we're still fully capable of doing that. But if we can reduce that by percentages, we're helping with social distancing. We're helping not waste personal protective equipment. And we're helping provide convenience to people. You know, a lot of people are working from home right now. If you think in normal times, when maybe I've had surgery and I'm back to work, I could take a half day to go see my surgeon for 5 minutes. I knew the incision was okay. I'm back to work. You know, I'm okay. But we know, look, I have to travel. I have to take a half day of work. There are things we can really do that benefit everybody. And those are the areas we're looking to get into.
So, but what if you call in and your doctor's unavailable, say on vacation? What happens after that?
So
do they say, well, there's a covering doctor, and then what happens?
Yeah, so we follow the exact same thing as before COVID. You know, if the doctor has a couple, you know, if they're a single provider practice, they're probably going to refer you to an urgent care or emergency department as needed. That we don't really have a lot of those anymore. You know, everybody's got a partner. And no different than when my doctor's on vacation, if I've got an acute issue, something that needs to be dealt with right now, a lot of times they'll say, hey, you know, your doctor's gone, but this doctor is here covering for them today, and here's the appointment time they have. And again, urgent care is still there for us. You know, the emergency department, most of the stuff we're talking about is not emergency department, you know, capable.
Yes.
You know, we don't want to go. We're trying not to go there for that. You know, that's.
But would they be able to prescribe something for you, having not seen you?
If they've seen you over video?
If the doctor was a covering doctor.
Sure, if they're doing a visit with you? Yeah, absolutely. Absolutely.
Oh, what a blessing that is. And it's a blessing beyond currently, I mean, for someone who's up in years, for someone who's broken a leg, for someone who has, you know,
Yep.
anything.
Yeah.
We're returning to what it used to be in my youth, which is doctor came to you.
Yeah. Oh,
it's just in a different way.
Yeah. You know, that patient-centered medical home, it is an initiative that people will see over the next few years. I think it will be accelerated by this. I suspect a lot of people thought things like virtual care were futuristic. You know, it was, well, it's cool for a very small group of conditions. And I think what this has forced is it's shown people, look at how big this could be. It's not the answer to everything. It's not. And, you know, there are things that, you know, I will still forever take my kids to the pediatrician to see the pediatrician in person for their wellness visit. I want her to listen to their lungs and check out all their joints. That's good health care. But does she need to see them every time they have strep throat? Probably not.
What did you have to change or relearn or think differently? Well, I mean, we're all in this together. Yeah. We can't predict tomorrow, really.
Yeah.
From a patient care or a functioning hospital stance, what did you have to think differently or do differently or emphasize more or less?
Yeah, I mean, the short answer is everything. I mean, you know, in terms of COVID, we really have 3 or 4 huge initiatives that are around that. You and I have talked about that. What do I do in my normal healthcare life? You know, I have essential hypertension. I'm on high blood pressure meds. I have since I was 19 years old. You know, I still need them, you know, and I still need a doctor to manage that stuff. So that's one bucket. What do we do with the 2,000 people that have called us in the last month to say, I'm worried I've been exposed. Do I need a test? How do I get a test? I don't know where to go. I don't want to go to an ER. That we had to figure out how to handle that. You know, now I've had a test and I'm in a parking lot because I'm doing a drive-through test. Yeah, that's what we do. You don't have to leave your car. Somebody's meeting you at your car to give you your flu test and your COVID-19 test. And I need to talk to the urgent care doctor that's inside. And, you know, if we do that with 100 patients a day, think of all the personal protective equipment we waste during that. Can I put them on an iPad and have them talk to you at the car? We've had to do that. So all those things needed reevaluation, and we've attacked them in many different ways. The first thing we did, and a lot of hospitals did, we put a tent up outside of our emergency departments because, again, think about sitting in that waiting room. The person with the broken foot could be sitting next to the person infected with COVID-19. And that's not good social distancing. It's not good medical practice. Our EDs very, very smartly put tents up outside. You want to talk about having to think on your feet. They went from a nice, cozy emergency department laid out for great patient flow to a tent outside the ambulance bay. But that's what we had to do. We looked at that and said, look at all the donning and doffing of personal protective equipment that has to happen for doctors and staff to come in and out of that tent. So the very first thing we did, we put an iPad on a pole, put an iPad in the doctor's lounge, or doctor's workstation, so the doctor could see the patient. The nurses out there, not the lounge, they weren't eating lunch at the time.
How much were the influence of county health or state health or federal health in your thinking of what to do? Who is the boss there?
You know, our teams that work in terms of the overall pandemic management work very, very closely with the local health department, the state health department, and internally we run what's called an incident command. So there's daily meetings. We've been able to come off them. I think they're every other day now, but for about a month and a half, they were every day, 8 a.m., a series of meetings through noons for different teams, because there's the working together as a community, and there's a team that figures out how to tie all that in. And then there's the operations of, okay, how do we do this? Our life is different. We've got tents set up outside. We went over to Midland's East End building right downtown, in the beautiful East End building that we have, and commandeered half of it. We had telephone crews running wires. We were boosting the Wi-Fi in there. Doctors that had never stepped foot in there. My team's central office is still there to this minute to figure out. We call that our telehub. It's where anybody can call that number and get a COVID screening from a doctor. It's where all our MidMichigan Health calls we're going through. There's been 2,000 of them, and we had to build that in 6 days.
And I understand treatment is variable.
Yeah.
It presents differently, so you can't say I learned how to do it. You're starting with a pool of ideas, but
exactly. And that was one of our approaches clinically. Our clinical team, our partners in the Mid-Michigan Physicians Group, Dr. Shannon Martin, who is our primary care council chief. She's a physician at East End. She took lead on this. She's amazing. Great physician, great leader, and really partnered with us well. And what our clinical side is able to do, when we have that centralized approach, every day they're reading the CDC best practices, the Department of Health and Human Services best practices. When the testing guidelines change, minutes later, they're changed at MidMichigan Health. It's real-time interactive, led by our providers, our physician leaders, and our quality department, our safety department, our infection prevention department. It's a really, you've said this a lot of times, we're all in this together, and it's as a community and it's as a hospital. It's put areas that, I never had to sit there at the table right next to quality every day to say, how are we going to do this? They're great. I work with them a lot, but everybody had to get in a room because we had to make a decision, and an hour later, a patient needed to be cared for by it. We were
terrible death, that suffocation.
Oh yeah, we were sitting there at East End and trying to figure out, how are we going to connect with all these people? Our goal, and the way it works today, you can call our telehub concerned you have COVID-19, and we want you on camera in 5 or 10 minutes from the time that we've even found out you exist. And that's really hard to do, really hard to do. And we were sitting there on a Wednesday. We opened at a Thursday at 8 a.m. At Wednesday at 2 p.m., we discovered the software that our entire network is built on. And we had tried everything. We tried Zoom. We tried our inherent telehealth software. We tried Skype. We tried Facebook Messenger. We tried FaceTime. We tried everything. Anything, you name it. We Google Chat. We tried it. And we were struggling to come up with a good solution. You just have to be extremely agile. And, really in the end, I can be very proud of MidMichigan Health and say this without reservation. MidMichigan Health is a patient-centered organization. I've worked for many healthcare organizations. I know one when I see it. And MidMichigan Health truly puts the patient first and is willing to make decisions as long as they're in the best interest of the patient. And I think those type of things, having an agility, a willingness to try and fail at new things and to be innovative, led us to be very successful in this pandemic.
So does the hospital have, prior to this, and they must, have some sort of catastrophe planning?
Oh, yeah. Yeah. So we have a well put together disaster plan. And it has a pandemic response in it. And that pandemic response has been utilized since day one. If you were to go to our boardroom in Midland, which is our incident command center right now, there is a giant, I mean giant, the thing's gotta be like 6 foot wide and 8 feet tall or something like that, organizational chart of what roles do you need in a disaster? Who is the incident commander? Who's the operations section chief? And we practice those things. Minimum, large scale, twice a year, but much more often than that. We go through and we bring, sometimes it's high school kids that are they put makeup on that makes it look like they were hurt and there was a plane crash. We participate regionally in that type of stuff. We test our system all the time to say, okay, normal business is going on. What if 50 people were hurt in a bus accident right now? What would we do? 2-3 years ago, we invited local fire, local police, local EMS onto our campus when our brand new corporate building was built, and simulated a mass shooting, what it would be like there, involving them physically removing people that were acting like they were injured from the building, egressing them out, loading them in ambulances, taking them to our emergency department, simulating them through the OR. We practice this stuff. You have to practice this stuff.
What would you add, Tom, to that program or several things perhaps, as a result of the experience we're all living through from a hospital point of view?
That is an excellent question. And this will require what we call a massive after action summary. It's weird. I don't know how you add this. It's that knowledge of, look at how fluid we can be. When we were forced to adapt, our business model changed overnight. And by the way, we take care of people. That's what we do. And that's what people need. But we're not doing elective surgeries right now. You can't really come in and get an elective x-ray or, anything like that. That was our bread and butter, and that changed overnight. And look at us, we're still standing, and so I think a lot of it is always communication. I will tell you the number one thing that becomes difficult in any crisis, and the first thing to break down is communication. And that's not unique to us. We know the military tells us that, the government tells us that, sports teams tell us that. That when times are stressed and we get anxious, there's a saying that's popular around here: anxiety makes us stupid. You don't think clearly when you're anxious, and it's learning to take a breath. It's very easy to get irritated by somebody who you might feel just doesn't think what you're saying is important. But you got to take that step back and learn they probably have 20 other things that are important on their mind too. I got to tell you, and it's not always work related. My wife is a nurse anesthetist here. She's right in people's airways all the time. She's in one of the most dangerous procedures that's out there right now, which is an aerosolizing procedure, intubating patients. She's somebody at extremely high risk of exposure, and that's on my mind at times when I'm here. And that understanding that I'm not the only one. I have coworkers here whose family members have cancer, or I have elderly parents that can't risk exposure. So I don't know how you put that in an after action summary, but I can tell you the number one thing in any situation like this that can improve things is just that ability to step back and communicate clearly and understand that we are all in this together. And I might not disagree with your idea because I think it's a bad idea. I just might think that it won't work, or I have a better one. And somebody might think that to me. And how do we stay calm in that moment and have the time and ability to get together and talk? Now we're doing it over video. We used to just go meet in the office. We can't do that anymore. So that type of stuff is probably my biggest takeaway. But I will say, I don't have many large criticisms at all of the way this was handled. I think we were very well prepared. And I knock on wood because we don't know if this is over. We don't know what the future says. We don't know if it pops back in the fall or what happens when we start going back outside. But I do trust that the foundations for the right decision are there. And that's I think, the best you can hope for at a time like this.
And probably you will be doing, if you haven't, or upgrading the cleanliness or whatever you call that, the infectious, whatever.
Yeah. We were a very cleanly place before that. I could tell you it was we have executives that will 100% walk to this hospital. If there is something on the floor or a spot that doesn't belong, it will be addressed. And that's important from a customer satisfaction perspective. how confident are you in care if you walk into a hospital and it's dirty? You know, how
you
much?
You are correct.
You know, how you know, so is it just to aesthetically please people? No. I mean, you know, how much do you trust that we're doing proper, you know, sterile processing and surgical technique if we can't pick our floor up? So that sort of stuff has always been very important to us. And I will tell you, the head of facilities, Mike Erickson, he's right at those incident commands. He talks about what the housekeeping crew is doing here. You know, they're a very, very essential function. I mean, I know the word essential is getting thrown around left and right these days.
As a patient or a client, I always look at the lights. If there are dead bugs in it,
yeah,
I get nervous,
me too.
and I report it.
Yeah.
Anyway, thank you so very much for joining me today. It's really, you told me really something very important. And it isn't just technically trained. It is who you are as a person and how do you like your day structured. And there's some of us who just love it. Give it to us, all the change. And there are others who are not. And luckily you are well positioned for this, and actually in a thriving field. What telemedicine can be doing in the next few years is really remarkable. But it doesn't change the human relationship. But you see how easy we do. I never saw you before. I never met you before.
Yeah.
So anyway, I think.
Yeah. And we don't want to. We don't want to take it away.
Where you are, what could be better?
Yeah.
And I so appreciate your time. I know it's particularly stressful and busy right now. And give a round of applause to your wife as well.
Yeah. Oh, she's great.
Thank you. Thank you so much.
Thank you. I appreciate it. I appreciate you having me.
To contact Junia, send her an email at juniadonsthespark@gmail.com. For more information, program schedules, and news about future guests, go to www.juniadonsthespark.com. Thank you for joining us. See you next time on Junia Doan's The Spark.
Local productions seen on Delta College Public Media are made possible with support from viewers like you. Thank you.